I'm Sue Ellen Reed, Director of Education at Baptist Medical Center. Today we're going to be talking about traditional and alternative healthcare delivery systems. Recent advances in patient medical care have, to a large measure, brought with them a rapid escalation of healthcare cost. Transplantation of a major human organ, for example, the heart or a liver, cost in excess of $100,000, and that's just for starters. Presently, there's a concentrated effort by government, the public, third-party insurers, patients, and the medical community to scrutinize the cost-benefit and cost-containment aspects of healthcare. Cost containment may be achieved either by regulation or by competition. Today, to discuss the recent developments and emerging alternatives to traditional healthcare delivery systems is Dr. S. Sandy Sanbar, physician and attorney. Dr. Sanbar, first let me ask you, what has been considered traditional healthcare?
Traditionally, physicians have been solo practitioners. You know, upon finishing medical school, a physician would open his or her own office solely, and they may have privileges in one or more hospitals to admit patients for patient care in an institution on an inpatient basis. Now, if the solo practitioner wants to leave town or go on vacation, he would have to find some coverage by another appropriate physician. Another type of or form of medical practice is the sole proprietor. The sole proprietor differs from the sole practitioner in that a single individual owns an unincorporated business. That business is called sole proprietorship, and that may include a large number of individuals, including physicians, who are merely employees of that sole proprietorship. Some physicians have opted to be salaried employees, and as already mentioned, they may work for a sole proprietor or may work for an incorporated business or for the government and so on. Another traditional form of medical practice has been the partnership, which is an association of two or more persons who are physicians, co-owners of the business, and here we're talking about a medical profession. Of course, that should be for profit. Now, while the partners comprise the partnership is treated as a separate entity from the two or more physicians. These form the physician, and they share in the profits and the losses of the partnership. In the event of losses by the partnership, then the partners are liable individually and personally. Now, to limit this liability, many physicians formed corporations. A corporation is created by law, and as such it is a separate and distinct entity from the shareholders that own its stock. In a professional medical corporation, the shareholders are, of course, doctors, but other professionals could also incorporate, and that could include nurses, dentists, physical therapists, and so on. Now, the corporation is an artificially created legal entity, a person which can sue and be sued in its own name. And therefore, it is subject to state and federal taxation. Additionally, such a legal entity must be incorporated in accordance with the laws of the state in which it is created. The management of the corporation is centralized. There is a board of directors that is elected by the shareholders, and in turn the board of directors choose the officers that run the corporation. Now, the shareholders do not play a direct role in the management of the corporation, and because of that, the corporation affords limited liability to corporate shareholders. The shareholders are not personally liable for the debts of the corporation. And there are two other features. The ownership interests in a corporation are freely transferable from one to another. And in the event there are changes in its shareholders, the corporation continues to exist even after the death, withdrawal, or retirement of its shareholders. One variant of a corporation is the S corporation. Prior to Subchapter S revision 1982, S corporations were referred to as Subchapter S corporations. The Subchapter S corporation of the Internal Revenue Code allows corporation shareholders to achieve limited liability of the corporate status and at the same time avoid double taxation of corporate income. This, however, is done at the expense of various tax benefits that are available to corporations. Another traditional form of medical practice, which is slightly more complicated than a sole proprietorship, is an expense-sharing arrangement between two or more doctors. Here the doctors simply agree to share some of the costs, some of the office space, and some of the staff, while remaining sole proprietors. This is particularly advantageous to doctors who do not wish to be personally liable for the debts and contractual obligations of, or torts, of other doctors with whom they share expenses. So what we have then is the sole practitioner, the sole proprietor, the salaried employee, those that form a partnership or a corporation, or an S corporation, and then we have the individuals that elect to enter into some cost or expense sharing arrangement.
In this program, we're addressing alternative healthcare delivery systems such as health maintenance organizations, preferred provider organizations, surgery center, emergency centers, etc. Maybe we need to look at what are some of the reasons for the recent development of such organizations. Why are they coming up as they are?
Well, in your introduction, you alluded to the rapid escalation of healthcare costs. And this, to a large measure, is responsible for some of the changes in the healthcare delivery systems and the creation of health maintenance organizations and preferred provider organizations and others. You also pointed out that cost containment may be achieved either by regulation or competition. As you know, the government utilizes the regulatory approach as an attempt to introduce economic controls. For example, in October 1983, the federal government implemented the drug-related group programs, and the purpose for the establishment of the DRG programs is to control the cost of health care. Now, the private sector, on the other hand, attempts to control health care costs by competition. And what we are trying to do is to develop some solutions to control cost while simultaneously maintaining and expanding the share in the consumer market, and this will help the healthcare providers. Now, it is the competitive approach which has led to the development of the several alternative systems of healthcare. Healthcare plans have therefore developed which have one common thread: the presence of an effective market incentive that induces physicians to use hospital and other resources economically. There are other reasons for the development of alternative healthcare delivery systems. These include an uneasiness on the part of certain physicians who find their practices dwindling, and there are increasing number of physicians who are entering the market with the same number of patients, and the physician-patient ratio in some parts of the country is uncomfortably low. Furthermore, some hospitals are limiting the number of admissions of physicians to the medical staff, and some new physicians are finding it difficult to work in certain hospitals. The net result is the emergence of an organized medical staff, separate from the hospital, who will negotiate on behalf of the medical staff with either the hospital or third-party insurer. However, the main reason for the development of alternative healthcare delivery systems is cost containment.
Let's talk about HMOs, or health maintenance organizations. If I'm not mistaken, they've actually been around for some time, haven't they?
Yes, they have. Health maintenance organizations, HMOs, have been around for some time indeed, approximately 50 years. There are two types of HMOs, though. The prepaid group practice, which is PGP, of HMO, and the second is the individual practice association, or the IPA form of health maintenance organizations. In 1978, Enthoven, in his article entitled How to Cut Cost Without Cutting Quality, pointed out the features of a prepaid practice type plan, which has built-in economic incentives as follows. He said, the essential principles are that a group of physicians working together to create comprehensive health care services for a fixed prospective per capita payment to a defined population of members who have enrolled as a result of their free choice.
Okay, how many forms of prepaid group practices of HMOs are there?
The prepaid group practices type of HMOs, there are two. One is a group model and the other is a staff model. The PGP, prepaid group practice, which is the group model variety, simply represents a group practice clinic that is made up of a group of physicians who are organized either as a partnership or a corporation. And as you can imagine, the group, which is made up of the physicians, contracts with the health maintenance organization to provide care for the subscribers. The health maintenance organization does not employ the physicians, who, as a group, receive a capitation plus share of the program's net income as a group. In turn, the group practice clinic pays the participating physicians either on a fee-for-service basis or by salary. For examples of the group model prepaid group practice of HMOs are the Ross-Luce medical groups and the Euclid Clinic. The second form of prepaid group practice is the staff model. Here, the physicians are employed by the health maintenance organization. The physicians receive their salary, and they may receive a portion of any surplus if premiums exceed expenses at the end of the fiscal year. And this is an incentive to cost containment. Examples of the staff model prepaid group practices of HMO is PruCare, Kaiser Permanente Medical Care Program, and the Harvard Community Health Plan.
Can patients choose their doctors in a prepaid group practice of HMOs?
We must remember that prepaid group practice is made up of a closed panel of physicians. This applies to both the group model, PGP, and the staff model, PGP. The subscriber, or enrollee, is obligated to obtain all medical care through that closed panel of physicians. If the enrollee requires special care that cannot be provided by the closed panel, then that enrollee will be referred by a member of the closed panel to an outside physician. In general, the enrollee has no choice in the outside physician.
We've discussed patients' rights of choice in prepaid group practices of HMOs, but what rights do physicians have? Will they have any choices about whom they treat?
That depends on whether the physicians are working in a staff model again or a group model. In the group model, prepaid group practice, the physicians must agree to render medical care at least 50% of their time to enrollees or subscribers of the health maintenance organization. This is for the purpose of meeting the standards for federal qualification. Hence, the physician in the group model, PGP, are generally free to treat fee-for-service patients as well, who are not enrolled in the health maintenance organization. In contrast, the physicians in a staff model PGP treat only patients who are subscribers in the health maintenance organization.
You mentioned standards of federal quality of HMOs, I think. Would you explain what those standards are?
Yes. Under the Health Maintenance Organization Act of 1973, Sue Ellen, there are certain criteria or requirements which have been designated that should be met before an HMO may qualify under the federal law. These requirements include a basic benefit package, an open enrollment annually, a defined consumer representation on the board of directors, and coverage based on community rating rather than experience rating. The Health Maintenance Organization Act of 1973 also provides that if an HMO is available in the area, that HMO must be offered as an alternative choice to conventional medical care coverage by employers with more than 25 employees. And HMOs have distinguishing characteristics. They define their population of enrollees. Advance payments are made by members for specific periods, and medical services are provided on a direct service basis rather than on a fee-for-service basis or indemnity basis. Emergency care, however, as we mentioned earlier, is included for bona fide emergencies, and enrollment, of course, is voluntary.
Let me ask you a two-part question. Do prepaid group practices, the PGBs, achieve the goal of cost containment, one, and two, do they maintain quality medical care?
The prepaid group practices, both the staff model and the group model, may be a profit or a non-profit organization, and it may devote itself to primary care or may include a broad range of specialties. Furthermore, they may or may not own hospitals. Thus, an answer to your question will have to be a broad one. Studies of health maintenance organizations have shown that they can diminish the cost of health care from 10 to 40%. And this is according to a 1980 report by Luft, L-U-F-T. This diminution in health care cost is principally attributable to a reduction in the hospital rates, coupled with more efficient operation and greater economy. In 1978, Eindhoven listed several advantages of prepaid group practices that pertain to economy and quality. And those included the ability to budget prospectively by the organization, of course, enhancement of opportunities for quality control, incentives, both economic and professional, to match the specialty mix of physicians to the need of the population, and another incentive to match carefully the facilities to the needs of the enrollees. Also, in cases of multi-specialty groups, there is the availability of consultations, stimulation, and reassurance of mutual professional support.
You talk about a lot of advantages, so I think it's only fair then that I ask the question, what are some of the more serious disadvantages of the prepaid group practice of the HMOs?
Some of the disadvantages to the prepaid group practice of HMOs include there is a perception that the care is impersonal. And physicians also are reluctant to accept what is viewed by them as limitations on their professional independence. Patients, too, need to change physicians in order to join. And there we must remember that considerable time is also required to organize and establish a financially sound prepaid group practice of an HMO. We must note that prepaid group practices have been around, as we said, for some 50 years. But to date, they comprise only some 5% of the population of the United States that are enrolled, except in certain places like California and Minnesota, where the percentage rises to 20 to 25%.
Okay, let's talk for a minute then about IPAs, the Individual Practice Association of the HMOs. How do they differ from the PGPs, the prepaid group practices?
IPA, Individual Practice Association form of the Health Maintenance Organization, is an organization of physicians who join together on a voluntary basis, and they agree with other organizations to provide medical services to a defined group or population. Thus, the physicians who are organized as an IPA practice in their own offices. They use the fee-for-service basis, and the physicians obligate themselves to provide comprehensive health care to the enrolled population of that HMO for a fixed prospective periodic payment. However, the physicians retain the right to serve the fee-for-service patients who are not enrollees or subscribers to the IPA. And the physicians are also not limited as to the amount of time they must devote to treat non-enrollees. This is in contrast with the PGPs. You recall that in the prepaid group practice, the physician may treat only patients who are subscribers of the HMO in the staff model PGP, and under the group model PGP, physicians must agree to give at least 50% of their time to enrollees of the HMO. Now, in the IPA, Individual Practice Associations, the physicians are not limited as to the amount of time they would devote to the prepaid practice.
Let me ask you this, then. In the IPAs, the Individual Practice Associations, how does one reconcile the prospective capitation payment by subscribers with the physician's fee-for-service reimbursement?
It's not easy to reconcile the prospective capitation payment of subscribers and the fee-for-service reimbursement of physicians in the IPA setup. It is difficult. What happens, however, is that an arrangement is created whereby subscribers pay their fees to the IPA. And then the IPA reimburses the physicians according to a formula that is agreed upon in advance. In essence, what happens in an individual practice association is that physicians agree on a maximum fee schedule and bill the IPA rather than the subscriber when they render a service. The IPA often agrees to reimburse 80 to 90% of the agreed upon fee for service, and the remainder of the money is held back in reserves. At the end of the fiscal year, the surplus is paid in part or in whole to the physicians, and in the event of a loss, the physicians share in the risk. As you can imagine, such an arrangement creates a financial incentive for the physicians to contain the cost of health care.
Okay, let's explore the alphabet a little bit more here. How do the IPAs, the Individual Practice Associations, differ from FMCs, the Foundation for Medical Care?
Individual practice associations, such as Group Health Plan of Northeast Ohio or Physicians Health Plan in Columbus, Ohio, these include a feature that payment of hospital cost of subscribers, or they may cooperate with an insurance carrier that offers insurance policies. Now, there are foundations for medical care which are slightly different but in some ways resemble IPAs. Both IPAs and the Foundations for Medical Care reimburse physicians on a fee-for-service basis. They differ in the financial risk borne by physicians. Physician-sponsored individual practice associations, or IPA, combine the function of providing the insurer and the subscriber, and there is a risk on the part of the physicians. In contrast, under the Foundations for Medical Care, FMCs, the physicians do not bear the financial risk if premiums do not cover the cost of services provided.
Okay, tell me then, Dr. Sanbar, I guess kind of in summary form, the advantages and disadvantages of the IPAs, the individual practice associations of HMOs, health maintenance organizations.
IPAs, which are types of health maintenance organizations, have the following advantages. It can be established with relative ease and with minimal expense. Physicians continue to practice in their offices with minimal change in their practice style or practice habits. The fee-for-service is maintained, and the patients keep their own physicians. But among the disadvantages of IPAs is the relative poor matching of numbers of participating physicians or specialty mix to the needs of the enrollees. And there is poor motivation to limit costs or limit physicians who generate high costs. Apparently, individual practice associations have not succeeded in controlling cost, and hence the cost to the enrollees of IPAs are generally not below conventional insurance rates.
Okay, if you would, can we move on and talk about PPOs, the preferred provider organizations?
PPOs, preferred provider organizations, represent a newer health care delivery system alternative. The primary objective is, again, cost containment of health care. The setup is simple. Health care providers that are made up of physicians and hospitals form associations. Then the associations of doctors or healthcare providers and hospitals will contract with an insurance carrier or with employers or third-party administrators to provide comprehensive medical services on a fee-for-service basis to subscribers. The negotiated fee schedule generally includes discounts, and these discounts range from 5 to 20%. PPOs have a panel of providers, and these include hospitals and physicians, and their numbers may or may not be limited. PPOs also have some form of control mechanism and a method for review and utilization and or claims, and the turnaround on claims by insurers is rapid. There is no lock-in of consumers. There is flexibility in the choice of the provider, and the financial incentive for choosing such a preferred provider is also there. The entry point or the gatekeeper in the PPO system is the primary care physician. PPOs are growing rather rapidly, and there are some examples like Northern Ohio Health Care Provider Organization in Cleveland, Mountain Medical Affiliates in Denver, United Health Network in Southern California, and California Health Network in the San Francisco area, and so on.
Okay, how do PPOs, the preferred provider organizations, differ from both types of HMOs, both the pre-paid group practice and the individual practice associations?
As you recall, we mentioned earlier that under a health maintenance organization, be it prepaid group practice or individual practice association, the enrollees prepay a capitation amount, and the physicians are at financial risk for patient care. Patients are locked in. They cannot use any provider that they so please. In contrast, under the PPO, Preferred Provider Organizations, there is no capitation amount that is prepaid to the providers, and the physicians are not at financial risk for patient care. Furthermore, the patients are not locked in, and they do not have to use that hospital or doctor, the preferred provider. Patients are free to choose. However, patients are encouraged to use preferred providers through incentives in the form of waiver of deductibles and existence of co-payments. What PPOs attempt to do is to be equitable to all parties concerned, the hospital, the doctors, the patients, the insurers, the employers. As to doctors and the hospitals, what do they get? Well, they're promised minimal financial risk, rapid turnaround on claims, an opportunity to maintain or expand their patient basis and therefore compete effectively with other preferred provider organizations or HMOs. Patients, on the other hand, would maintain their freedom to select their physician and yet pay less for their health care. Similarly, the employer, purchaser, would have a cheaper health care benefit to pay for and would also strengthen their bargaining power with the health care provider. The insurers, on the other side, have a new competitive product which can be tacked onto existing benefit plans. So there is something for everyone in PPOs.
How are PPOs, preferred provider organizations, structured vis-a-vis the doctors and the hospitals? Are they associated?
There is no single structure of a preferred provider organization. The PPO structure varies according to the local community, the conditions, and the marketplace. The doctor-hospital arrangement in a particular PPO may have the doctors as a completely separate body of medical staff and the hospital totally independent. And this is on the one extreme. On the other extreme, the doctors may be the owners of the hospital. And there are, of course, gradations in between. Some of the physicians sometimes are even employees of hospitals. But all PPOs have one strong marketing feature, and that is control of utilization. In general, this control of utilization reviews offices, notes of doctors, as well as in-hospital patient utilization. PPOs also commonly provide a mechanism for pre-admission certification of elective admissions, and this is particularly true where there is elective surgery. Control of utilization and pre-admission certification is particularly important where there is federal reimbursement for medical care that is based on diagnostic-related groups, the DRGs.
Hey, let me try another set of initials on you. What about the new thing called EPOs, the Exclusive Provider Organization?
EPOs, Exclusive Provider Organization. This is a new health care plan that is another alternative. It made its name in California, and it was the byproduct of the recent California legislation which actually enabled PPOs. It is really a spin-off of PPOs. The Exclusive Provider Organization is non-capitated. It is structured against fee-for-service, and this is similar to the Preferred Provider Organization, but it does not enable employees to choose between preferred and non-preferred providers. One might look at EPOs, Exclusive Provider Organizations, as representing a compromise between HMOs and PPO structures. The Exclusive Provider Organization has total control as to where the provider dollar goes, and the patient loses the ability to go to the provider of his or her choice. In this regard, The EPO, Exclusive Provider Organization, is similar to the Health Maintenance Organization. But the full risk of the HMO is deleted, and therefore there is less incentive for keeping costs down. EPOs, Exclusive Provider Organizations, are looked at as a kind of a marketing tool, or basically a covenant of competition between the administrator and the insurance and the provider group and the hospital.
Let's turn for a moment to ambulatory surgical units or centers, and I think I've heard them called Surgery Centers. Where do they fit in the scheme of cost containment of health care?
Ambulatory surgical centers, or surgery centers, provide a place where minor surgical procedures can be performed on an outpatient basis. And as a result, healthcare services are provided in a more cost-efficient manner. And this has increased price competition in the private health sector. Patients are learning quickly that they can get very good treatment at an ambulatory surgical center, including plastic surgery, and still go home at the end of the day and rest in the comfort of their surroundings. Surgery centers have been beneficial to all parties concerned, the doctors, the patients, the hospital, everyone has benefited.
How about the new concept, and I don't mean this facetiously, but we've heard it referred to as Doc in the Box, you know, the Jiffy clinics. I'm referring, of course, to the FECs, or the freestanding emergency clinics, or I guess so-called emergency centers would apply here too.
The freestanding emergency clinics, the FECs, or the emergency centers, represent another alternative to the traditional health care delivery system. The National Association for Freestanding Emergency Clinics, the NAFEC, defines emergency centers as independent emergency medical facilities which are staffed to provide high-quality patient care, and in doing so, they offer, as compared to the private doctor's office, easier access, a wider scope of services, and longer hours of operation. There are two different types of FECs, freestanding emergency clinics: the hospital-sponsored satellite and the independent, privately owned emergency center. The hospital satellite emergency center has the backing of the hospital, while the privately owned freestanding one does not have that luxury. And if it is unaffiliated with a hospital, it may confront issues of professional medical liability, including the possibility of misrepresentation, abandonment, the duty to consult, and the duty to refer. It is conceivable that in the near future we will witness the development of standards of care for privately owned freestanding emergency clinics.
One last question, Dr. Sanbar. Would you comment on some of the legal issues that confront PPOs, the preferred provider organizations?
The major existing legal problems that preferred providers confront deal with patient-doctor relationship, illegal price fixing, and peer review. There is no case law pertaining to the interference of patient-doctor relationship as yet. But in Arizona versus Maricopa County Medical Society, the U.S. Supreme Court held that the Medical Care Foundation, by setting fixed prices, was in violation per se of the antitrust, which is the illegal price fixing provision under Section 1 of the Sherman Act. What brings physicians and doctors together as preferred provider organization is the very agreement on the price to be charged. Cost containment is achieved via price control, and unless prices are competitive and below the local market, PPOs may not survive. It is the pro-competitive nature, however, the low prices of the PPO, which may in the future and in the eyes of the courts counterbalance the illegal price fixing by doctors and hospitals, especially when prices are not specified and fixed, but possibly referred to as less expensive or at competitive rates. As to PPOs and peer review, the McCarran-Ferguson Act does not exempt peer review practices from antitrust scrutiny. Such was the holding in Union Labor Life Insurance Company versus Pyreno. There, the Pyreno court found illegal certain characteristics of the agreement which are similar to peer review activities performed by preferred provider organizations. So PPOs represent this rapidly growing pro-competitive alternative to healthcare delivery system with at least two noticeable antitrust hurdles, namely price fixing and peer review agreements, both of which may conceivably be unavoidable consequences and an integral parts of the structure of doing business as preferred provider organization, or PPOs. So if I may conclude, traditional healthcare has been inundated by numerous alternative healthcare delivery systems. And these include the health maintenance organizations, and we have talked about the prepaid group practice and the individual practice association of the HMOs. Then we talked about the preferred provider organization, the exclusive provider organization, the surgery centers, and freestanding emergency clinic or emergency centers. The plethora of these organizations is the best evidence that none of them is truly ideal. Competition among healthcare providers will take different shapes and forms while at the same time attempting to contain the cost of medical care.
Thank you, Dr. Sanbar. It's so hard to sit here, I think, and not be reminded of the song, "The Times They Are Changing." And I think we've got so many new frontiers in front of us and so many alternatives to choose from that it's sometimes difficult for us to keep up. We hope this will be helpful to you in looking at alternatives and what they might mean to you.